of the public that are watching online as well as here in the room with us. I'm going to do a quick roll call of the council members just so that we can get a sense for who is out there.
Go ahead and begin.
So let me start with our
co-chairs. Dr. Casey Shillum, are you here?
Yes, I'm here.
Great. Nancy Murray? Make sure that you've unmuted. Alan Stevens?
I'm here.
Great. Ben Bledsoe?
Present. I'm present.
Great. Joe Caldwell? Joe, can you?
Yeah, I'm here.
Great. Diane Carrigan?
I'm here.
Great.
James
Shealy? Here.
Gisela Dolan.
Gisela Dolan? Brenda Gallant?
Make sure that you've unmuted
Your computer mics. Catherine Georges?
Okay, I see what the public's saying.
Catherine Georges? Rhonda Montgomery?
I'm here.
James?
I'm here.
Great.
Deborah Stonewalls?
Aloha, I'm in Maui with the flu, but I'm here.
Oh, glad you're here. Teresa Tanus?
I am on.
Great. Carol Street.
Okay. I know Carol was going to be in and out. She had a competing.
Our federal partners, Lisa McGuire.
I'm here.
Helen Lott?
Hi, I'm here.
Great. Do we have somebody from the FDA? Ursa? Joan Weiss?
I'm here.
Great. Bruce Fink? Melissa Gerald? ACYF, Jan Rothstein? Great. You're here in the room with us. Rosemary Payne?
Are you gonna share?
Mark Bathiatis? Hector Ortiz?
I am here.
Great. Jan Newsom? Melissa Harris? And Linda Davis
From the VA. And I know Melissa will be joining us after 1:30. She emailed me earlier. So I'm going to, we've taken roll, and I expect other folks will be on.
check. Is anyone else hearing something?
Just you asking that question.
I can hear some things, but not what I'm supposed to be hearing, I don't think.
Yeah, I cannot hear a speaker right now.
Yeah, we
Sorry,
can hear people.
sorry, Lance.
I believe Lance is
Not hear Lance.
muted and we are not able to hear him.
Just making sure that's what.
Yeah, I think that this is Alan. Can y'all hear me?
We can hear you, Alan.
Yeah, I think it's just Lance.
Yeah, we were just chatting. There was a lot of chat. No one was giving Lance a heads up, so I thought I would jump in
But
there.
if you're the boss, you can do that.
Yeah, the mic should be working.
Is that better?
Okay, we did something correct with it.
Maybe just.
Can hear you in Kentucky.
I can hear you now.
Okay, great. All right, thank you. Thanks, Lord. Well, it's better than no sound. Echo's better than no sound. So if I hit the rewind button, all the way back. Thank you. Glad to do this conversation. We got a packed agenda. Greg will cover that. Again, not sure how much people heard since we may have been muted, but again, we're just really honored at ACL to be responsible for helping stand up both Ray's and the grandparents and grandchildren efforts. And as I was mentioning, I know it's repeating a bit, but very proud that this fits so warmly within our portfolio, and that caregivers, of course, are the epicenter of the work that we do around community living, reinforced by one of the 5 pillars we have here at ACL. I gave a lot of thanks to a lot of people.
Laura with Davis calling back. Apparently we're playing phone tag, so Tag, you're it. If you still have any questions for me.
Okay. And I listed some highlights, but again, for sake of time, I won't go back over those again. Just so much work has happened in the past quarter, and I'm really grateful for that. So thanks to Greg and so many of the rest of you that have really been leaning in, and some great things have happened over the past quarter. Super excited about the quarter to come. I had just started talking when I think we got the volume to work around the RFI, which all of you, of course, are familiar with the RFI. Just closed on Friday the 7th. Super excited to know that over 1,800 submissions were offered to us. A general breakdown, a lot of feedback around, of course, the importance of respite, the financial impact of caregiving, issues that, of course, relate to the workforce, cutting-edge services, and a variety of other things. So as the team begins to distill those 1,600, 1,800 submissions down, we look forward to kind of sharing with you what the RFI produced relative to, again, information that we as a council want to certainly take under consideration and weigh in conversations moving forward. So Greg gets out to everyone what he called a preparation guide. I'm an old higher education guy. He used the word homework. I hate homework, don't you? That just makes my skin crawl. But it was a preparation guide, and I read through it. I hope all of you did. It kind of sparked some excitement in me around a number of key things. So while certainly the council should be ready to kind of weigh in this afternoon on all of those elements, just wanted to share, when you think about the guiding principles and the decision-making process and the goals, there's a lot that we get to talk about this afternoon that we hope will really position us to be the most effective we can be. I wrote down a ton of thoughts, and when I initially read through it, and I hope you did as well, as a couple of examples under guiding principles, I really am drawn to the inclusivity of who is a caregiver, and of course, so much focus in recent conversations we've been having around, caring for a veteran, or maybe folks out in rural parts of our country. How about tribes? So just again, the broadness of how we can successfully be inclusive and yet recognize so many different types of caregivers. And I'm a big fan also of public-private partnerships, and we called that out in the document. I think some element of the path forward has to involve stronger public-private partnerships in helping lift this. It's not solely the federal government's responsibility or any key partner. It's going to take a lot of us. Under the goals section, of course, resource identification. How do we make sure that folks in need find the resources they need as quickly as possible, and that information is effective, timely, helpful? That's another pillar that we have here of the 5 at ACL, and that is, again, helping link people to resources. I know it seems simple, and even when we're talking to folks on the Hill or across the country in different conferences, we try to help people appreciate, if we can do that well, think about the difference that alone can make. Again, helping really move further upstream when it comes to resource identification, helping families be prepared. And then also under proposed goal number 3, again on partners, my thought really jumped to how do we better utilize the faith-based community. Being from Oklahoma, I know that every community has 17 churches. I don't know. I mean, it depends on the size of the town. Churches everywhere. And so often those faith leaders are first ones to the situation. And most of those faith leaders, candidly, just aren't really sure where to direct folks. So again, I think there's a real overdue opportunity for us to further strengthen the faith-based piece. But again, lots of discussion to come on this. I just thought I'd throw out a few thoughts just so you know I did the homework as well. So that's important to know. Let me wrap up then. I want to call out 3 observations that I think are important that we throw out on the table as we launch into the rest of the agenda. So first of all, I can stress to you that from my perspective as the ACO Administrator and Assistant Secretary for Aging, there's really, I think, an incredibly high level of support for what we're doing. And that's sort of been the case, but I see it just continuing to slowly ratchet up. And I'm excited about that. Certainly the congressional interest is there, thanks to the advocacy of a lot of our colleagues and friends, but also conversations within HHS, with our own secretary and with HHS leadership around how connected almost everything HHS does, how connected that is to caregiving in so many different ways. The president's budget just came out a little over 24 hours ago, and you'll acknowledge that there's support there for this effort out of the administration. And then even the work that we're doing internationally. So we at ACL have been working over the last 6-7 months with the National Academies of Medicine. We're doing some international healthy longevity work, and inevitably when it comes to aging issues, caregiving is a topic. So the work we do here, while it feels very focused, I just have to remind all of you, it's very likely that the efforts here will really spread beyond even our own borders and probably positively impact conversations that are happening in other countries of the world. So that's exciting too. So that's one thing. The second thing is really a commitment to doing this work for caregivers and doing this right. We talked about this at the inaugural meeting. I know we're all in agreement, but I need to really stress that patience is critical. Sometimes these timelines can force us to sort of trip over ourselves, and we can't really rush this effort. We need to make sure that we appreciate how nuanced and complex and comprehensive the work is that we're doing, and it needs to be that way. We can't crank out just another report that's just going to sit on other desks and other bookshelves. We want to make sure that this one is different and that it sets the stage to really move the needle forward. So that's the second piece. And then finally, really the engagement of federal partners. We've got a number of federal partners on the line, but all of you can appreciate we're really now queued up to make sure that our federal partners, particularly around accessing what our federal inventory looks like, we've got some work to do there. We're excited about that. We're welcoming a new partner. I think our colleague from the Administration on Children's and Family should be participating, as well as, gosh, nearly a dozen other federal agencies and partners within HHS, because we do know that federal conversation is pretty critical. So those are the 3 things I wanted to quickly call out, but I want to close by, again, thanking all of you, and special thanks to Hartford and NASP and others that have really helped move things forward over the past quarter. It's so exciting. I'm grateful for all the moderators. When I looked at this agenda, I mean, we're pretty blessed to have some high-powered folks that are going to lead us through critical conversations. So my thanks as well to the council co-chairs and to all of you that are continuing to play a role. This is such a critical meeting, and as we begin to really narrow in on what things are going to look like relative to a national plan and what our goals and guiding principles, the decision-making process, all of that is so critical for this meeting. So I'm excited, I'm ready to go, and we're so glad that all of you are here. So thank you, Greg.
Thanks, Lance. I wanted to run through the agenda with all the council members. Hopefully you have that up in front of you, open on your laptop. We do have a fairly packed agenda over this afternoon and tomorrow. We're going to, by the close of tomorrow, I think my NASP colleagues and I hope that we can accomplish a number of very concrete things here at the close of the we definitely want to and need to finalize and adopt a clearly articulated set of guiding principles. That's really going to help shape and inform the work that we do. We need to also do some work on the goals that we've set. Back in August, the council agreed to a general set of very broad goals. Those 3 goals, we have the potential for a 4th, kind of have shaped the subcommittee structure, but we need to really have a discussion about the goals you want to achieve, and then hopefully vote and adopt a final set of goals, because those goals will then help to serve as the framework for a set of drivers or action steps that will begin to flesh out the recommendations that we make. And hopefully this agenda over today and tomorrow will get us to that point. We, and by we, I mean my NASHP colleagues and I, as well as the folks who work with me here at ACL, we see that the work of the NAPA Council, the National Alzheimer's Project Act Council, is a very good model for how we proceed, particularly with how the national caregiving strategy shapes up. And so Helen Lamont, who heads up the work of the NAPA Council, is going to kick off the substantive portion of our meeting today with an overview of the NAPA decision-making process that will hopefully get us grounded in the work that we need to do. And then following Helen's remarks, our council co-chair, Dr. Casey Shillum, will take the council members through an exercise to hopefully fine-tune our guiding principles. In the prep guide that you have, Wendy and I began to articulate what we think may be a common set of guiding principles that we can use. They're based on other guiding principles from New Mexico and California, who have attempted a similar effort as this, but on a state level, as well as the NAPA guiding values and principles. But we want to make this unique. We want to make it our own and reflective of the national goals for this project. So Helen, Dr. Shillum is going to take us through an exercise that will hopefully get us to that point. And then we need to fine tune our goals. And so our council co-chair, Dr. Alan Stevens, is going to work us through an exercise to build on and revise and expand the goals. And so hopefully in the week that you all have had the prep guide, the homework, and I promise I'll never use that term again, but we will be able to have a really rich discussion around that. Then tomorrow, we're going to get a bit more in depth on the driver diagram process, which will be this guiding process for helping us actually begin to flesh out the national strategy. And our council member from the Indian Health Service, Dr. Bruce Fink, is going to lead a discussion about that. And then following that, our third co-chair, Nancy Murray, will lead the council members through an exercise to begin articulating and developing some of the drivers and action steps that will help us achieve this goal. And then tomorrow we're going to dig into, at the close of the day, dig into a little bit in depth the work that NASHP is doing with the sub-grantee of theirs at the University of Massachusetts. They are going to be critical in helping us analyze and distill the more than 1,800 recommendations that we got and begin to make sense of them, put them into a logical order, and to begin looking at how we can use those meaningfully to construct both the report and the national strategy, and think ahead to some public listening sessions that will be unfolding around the country as part of this work. So just for a couple of housekeeping things for all of us on the council to remember. We are webcasting this entire meeting. So we've got not only folks here in the room, but the council members around the country who are tuned in. We're going to be webcasting the entire 2 days. There is closed captioning. Hopefully you all can see the option if you need and want closed captioning to be able to access at the bottom of your screen. For those members of the public who are tuning in via the webcast, if you have a question or a comment, we do have that chat box available. We may not be able to answer or address every question real time, but everything is being recorded and we can get back to you with a response at the conclusion of the meeting. For those members that are in the room, we'll attempt to reserve some time for questions and comments here and there as the agenda permits. For the council members who are online, please remember to announce your name when you begin to speak. That way we can keep an accurate track of who's speaking. And we don't have any breaks built into the agenda because of the short time frame, only 3 hours each day to get to a lot of different subjects. So if you need to take a break, feel free to step away. Just don't forget to come back. So with that, are there any questions from the council members before I turn it over to Kitty Purington at NASHP? Okay, Kitty, did you want to say a few words before we get going? Unmute your phone or your computer.
I may start to echo. Wow. Can folks hear me?
Yes.
Okay. Hold on just a sec. Well, thank you very much, Greg, and thanks to members of the RAISE Act Council. I just wanted to take the opportunity to thank everyone for your good work and for your dedication to this important topic. As you know, the National Academy for State Health Policy has been incredibly fortunate to receive funding from the John A. Hartford Foundation to support your work, to support the work of the council. And we have been really grateful to have Wendy Fox-Grage join NASHB to direct this project. So really doubly lucky. And she and the NASHB team have been working closely with Greg and the folks at ACL to identify resources and supports to help the council. I just wanted to give you a brief update on the work that we have been doing. As many of you know, Wendy is just wrapping up an extensive review. I think it was a total of 28 national sets of recommendations on family caregiving, totaling hundreds of individual recommendations. So she has been poring over those and collating and analyzing them. The council has seen those, and those will continue to be discussed with council members to guide your work. We have also engaged a faculty of experts from various disciplines, both to be ready to support the council with specific questions and technical assistance, but also to spread the word of what the council is doing to a broader audience. We are also working on a 50-state review of Medicaid waiver policies and taking a deep dive into how they support family caregivers in various ways through respite and education and training. That will be another resource forthcoming for the council and also for the public and for state policymakers. And as Greg mentioned, we'll also be bringing in additional partners such as UMass Boston to assist the council in reviewing the incredible response to the RFI and working through those responses and analyzing them so that that can be incorporated into the council work. So we are really looking forward to continuing this great partnership and supporting the council. And I would just like to turn it over to Ronnie Snyder, who is the Vice President of Programs at the John A. Hartford Foundation, without whose support and guidance this work really would not be possible. So thank you, Greg.
Thanks, Kitty. Can everybody hear me? All right, great. So good afternoon to everybody. Let me add my welcome to Lance's and to Greg's and to Kitty's. I and my colleague, Scott Bain, here at the Foundation are really excited to be here virtually with the Council at this second meeting. And so we want to also welcome any guests from the public. As Kitty mentioned, I'm Ronnie Snyder. I am the Vice President for Program at the John A. Hartford Foundation. And we are a nonpartisan national philanthropy that's based in New York City, although we operate nationally. We were established in 1929 by the family owners of A&P grocery stores, which some of you may remember. Our mission here is to improve the care of older adults. And we work in 3 different areas to do that: creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. So you'll hear just by listening to those 3 areas that they're mutually reinforcing. For example, making health systems age-friendly really means meeting the needs of both older adults and their families in all circumstances. So that's including when we're facing things like serious illness or end-of-life decision-making. We've chosen family caregiving as one of our 3 priorities because caregivers, you all know this, are the linchpin of care for not just one, but at least 2 people, themselves and the people they care for. And we need to identify them, to train them, and to engage them as core members of care teams. So we want to work collaboratively to lessen the physical and the emotional toll that caregiving takes. In other words, caregivers really, really need our support. The John A. Hartford Foundation is working hard so that age-friendly care can inherently support family caregivers and reach as many older people in America as possible. And we're working to do that quickly. We personally have a sense of urgency because we know that there are so many millions of family caregivers who need practical and timely help. the Raise Family Caregiver Act Advisory Council and the Resource and Dissemination Center that we've just funded at the National Academy for State Health Policy, thank you, Kitty, is one key way that we're working to get caregivers relief as quickly as we're able. So through the center at NASHP, we're bringing together experts and information that allow the council to develop policy recommendations. The policy as it's been, the center as it's been conceived is a public-facing resource for stakeholders with an interest in family caregiving policy. And it's also, later on in particular, a vehicle to facilitate more rapid dissemination and implementation of the council's recommendations. So we're really excited by this work. The work that's being done by the council, by ACL and NASHP is an example of the collaboration that's really baked into our DNA here at the Johnny Hartford Foundation. We work strategically with a whole diverse set of partners to ensure that older adults get the best care that is possible. Our collaborations involve lots of other funders as well, other funders and other partners as well, including, for example, work with other outstanding organizations to support caregivers like the UCLA Health and its Alzheimer's and Dementia Care program. And that particular evidence-based program is one of among 40 different proven caregiving support programs that are now included in a first of its kind online database. It's called Best Practice Caregiving, and it's a resource that was designed to help healthcare and social service organizations to select evidence-based dementia caregiving programs that meet the particular needs of the communities they serve. This was just launched by our partners at the Family Caregiver Alliance, the Benjamin Rose Institute on Aging, and the Gerontological Society of America. Please go ahead and visit that because Lance mentioned earlier linking people to resources, and that's exactly what this does. So I want to end there. I want to thank the council. Thank you, Lance and Greg. Thank you to NASHP, and thanks to everybody in the audience for participating. You're all doing such important work, and it's really critical to us that working together, we can really make a difference. We can change the status quo, and we can create a society where older people and all of their families are cared for and valued and supported. Thank you.
Thank you, Ronnie. And so thank you for those framing remarks. We are, I think, ready to dive into the agenda. As I mentioned earlier, our goal for this two-day meeting is really to make a lot of decisions, hopefully move the ball forward in the work that we're doing. And because we also want to use good examples out there where they exist for this process. And one of those is the National Alzheimer's Project Act Advisory Council. And so I'm very pleased to have on as one of our federal members on the council, Dr. Helen Lamont with the Assistant Secretary for Planning and Evaluation. Dr. Lamont's going to talk to us a little bit about some of the decision-making processes that have gone into the NAPA Council's work. And hopefully we can take from that some ideas and some thoughts with us as we begin to move forward with our own decision-making regarding both the recommendations that will be included in the report, as well as how we begin to build out that national caregiving strategy. So I'm going to go ahead and turn it over to Helen. Helen, if you make sure that you're unmuted, and we look forward to hearing from you.
Hi, everyone. I hope you can hear me. I've turned off all my microphones. I'm hearing feedback on my phone, but okay, there you go. That sounds great. Thank you. And I apologize for not having video, but the wonderful thing about web technology is it allows people like me who are recovering from the flu to be at home and join this meeting, whereas if we were in person, I wouldn't have been able to join. So I'm glad that I could be here today to share what we've done with NAPA and hopefully give you guys a head start in your work that we're about to get underway. Can you advance the slides, Greg? There we go. Okay, and you can go to the next one. Okay, so what is NAPA? You probably heard that acronym a lot. NAPA stands for the National Alzheimer's Project Act. It's just the shorthand that we use. And it's a very short piece of legislation, 2.5 pages, very, very similar to the RAISE legislation. It calls us to create a national plan on Alzheimer's disease being Alzheimer's disease and related dementias, to work collaboratively across the government to move things forward more quickly and to enhance the work that we've been doing to improve outcomes for racial and ethnic minority populations, and to create an advisory council to review and comment on this national plan and its implementation. Okay, next slide. So our advisory council is very similar in structure. We have 12 what we call non-federal or public members representing various perspectives, and then we have representatives from the federal government. I think I mentioned at our August meeting that this is a pretty unique structure, and we weren't exactly sure what to do with it at first, and we've been able to take advantage of the structure, which I'll go into in a little bit. But having both feds and non-feds was novel in 2011 when we were implementing this. So the group meets quarterly for advisory council meetings and then annually makes recommendations to the Secretary and to Congress on priority actions. And most of our work happens in 3 subcommittees. Next slide. Our 3 subcommittees come from the legislation in part because it said Alzheimer's research, care, and services. So we took that quite literally and have focused on research, clinical care, and long-term services and supports, recognizing, of course, that research also informs clinical care and long-term services and supports. So here, when we talk about research, we mostly focus on research towards essentially a cure for Alzheimer's disease or related dementias. So we have these 3 subcommittees. These subcommittees consist of both federal and non-federal advisory council members, but they all have a non-federal chair, and that was sort of important for us because we want to make sure that the non-federal or public members of the subcommittees are the ones who are really leading the work and giving the direction to what we are doing. The groups meet monthly by teleconference and have been since our inception. And the primary responsibilities for these groups are to craft recommendations, to share information among the members, and then to plan one of our big advisory council meetings for the year. So they provide information relevant to their recommendations, and we'll do a panel, for example, to talk more in depth about some of the recommendations. Next slide. And then on to our recommendations, which I'll go into a little bit more, but essentially we have a set of recommendations that are approved annually or adopted by the Advisory Council in July, and that informs the federal government's work towards the annual release of the National Plan update. And generally that update has been in the late summer, early fall, October. There's an October meeting, so we try to aim to have it out by that October meeting. So at our July meeting, the group votes on the recommendations, and then in October, we release the National Plan update, which hopefully reflects the input of the non-federal members through the recommendations and is there as a document laying out what we're going to do. I would say over the years, there's been quite a range in the level of ambition and the areas of focus. So we've had everything from federal funding for Alzheimer's disease research should be $2 billion to ASPE, which is my office, should do a study on dementia care models, which would be, a $100,000 research project. So quite a range of things that we're doing. And quite a range of specificity. When we started, the Advisory Council wanted to do work in different areas, and we weren't really sure what the role of the federal members was. And so we started with pretty broad recommendations. And as time went on, we realized that if we wanted the recommendations to actually be implemented, then it was beneficial for the federal members to provide input and to craft recommendations that were more specific. So for example, if there was a recommendation that was going to require legislation in order to be implemented, the federal members could say that. We could say, hey, we appreciate that you want to move that recommendation forward, but under existing authority, we're unable to do that. And so we've wound up with more specific recommendations that are more likely to be implemented because they're specific to who should be doing the implementation and what exactly needs to be done. The number of recommendations has varied greatly. I think in our first year, we had something like 38 recommendations. And in more recent years, it's been a smaller number, but there's quite a variety in the number and the detail of the recommendations, even within the year across the subcommittees. We always struggle with whether previously recommended items that were not yet implemented should be continued. So that's something that you'll always have to think about. If you make a recommendation, is it important to keep it, or do you just let it go and focus on something else? And then I provided the link to our NAPA recommendations over the years. Next slide. So I don't know if you can see it here, but I tried to do a comparison of sort of what the recommendations have looked like over the years, and I tried to pick one that was particularly relevant to this group. So in 2012, one of the recommendations was, and you guys might consider doing something like this, to fully fund caregiver support under AOA, the Administration on Aging. I think this was even prior to the creation of ACL. And so we had these high-level goals. You can also see HHS and state lead agencies should assure that caregivers' physical health, behavioral health risk is assessed and addressed regularly, et cetera, in 2012. In 2019, our recommendations were fewer, but much, much more comprehensive and specific. And if you go through it, there's actually quite a few sub-bullets that would get to the recommendation. So as you're thinking about what you want to do, you don't need to decide on this, but it's just a consideration for how you structure your recommendations and how you think about being inclusive, being ambitious, but also not biting off too much or losing the reader because you have so much information in there. Next slide. So in terms of our decision-making or recommendation-making process throughout the year, the subcommittees meet, and the subcommittee chairs lead the meetings and hopefully are getting their group to a set of recommendations. And then annually at the July meeting, the subcommittee chair presents the recommendations from their subcommittee. The group might make edits or add language or suggestions for expansion to the recommendations. I don't think I've ever seen a recommendation completely taken out during the July meeting. Generally, they're presented as pretty final. The non-federal members of the advisory council then vote on the recommendations. We decided early on, in part because there are so many budgetary recommendations and there's already a process within the federal government for the federal agencies to make budgetary, to provide budgetary input through the president's budget process, that the federal members abstain. So the non-federal members of the advisory council vote on whether or not to adopt the recommendations. And the recommendations are not often not completely final at that July meeting. The group will give authority to the subcommittee chairs to go and tweak or to make the changes that they've just discussed. But for the good of the order, they will say, yes, we vote to adopt this recommendation, pending these changes. And then in the late summer, early fall, the subcommittee chairs finalize their recommendations. They send them to me and to the advisory council co-chairs, and then the recommendations are sent to Secretary Azar and transmitted to Congress. Next slide. So I started on the NAPA Council when it began in 2011, and took a little bit of time off and I'm now back, but Lisa McGuire, who's on this council, Bruce Fink, and Joan Weiss have also been on it. And so I'd be interested to hear their input on it as well. I would say over the years, we've seen that leadership on recommendations is important for consistency, but the subcommittees will differ. So I don't think it's possible, or it hasn't been successful when our chair has said, okay, only 10 recommendations from each subcommittee, or only this detailed. There's always going to be differences across them, and it's worked out just fine. We haven't ever had completely consistent recommendations, or uniform recommendations, I should say, but the group of recommendations that come out are often very high quality and are useful for implementation, and quite a few of them have been implemented. I think it's important for all members to serve on as many subcommittees as they want, and that way you're not coming to that final meeting where the recommendations are presented and totally caught off guard by the recommendations that are presented and feeling as though you haven't had an opportunity for input. So we have folks who are on 2 or 3 of the subcommittees and are able to provide input on the recommendations as they're being crafted. So there's no surprises. The recommendations generally are pretty close to, prior to that full advisory council meeting, and I think that makes it a lot easier, so we're not wordsmithing in a very large meeting the recommendations. As I said, there's an opportunity for small tweaks, but in general, they're pretty close to done by then. And as I talked about a little bit, the recommendations that were specific and have a target agency or target implementer have become the ones that are most likely to be implemented. So the more that you can say, that you can know by talking to your federal colleagues, who in the federal government or even who on the Hill should implement this recommendation, and specify that and specify what exactly you're looking for, the more likely it is to get implemented. And it's really been a great collaboration between our federal and non-federal members. Federal members want this work to move forward. We're all as committed to it as the non-federal members, but we have constraints on what we can do. And so by helping to craft recommendations that are more likely to be successful, we all win. And then I've also noticed that there are some recommendations that are purposely ambitious and not feasible, and those are important to send a message. For example, saying that in the first year we should have had $2 billion for Alzheimer's disease research, we thought was completely not feasible. It was very pie in the sky. At that point, it would have been a quadrupling of the research funding for Alzheimer's disease, and this was in the time of sequestration, so it was very, very unlikely to be implemented. But the Advisory Council set that very ambitious recommendation and can continue to do it over the coming years. And sure enough, with the Advocacy Network support, the federal research funding for Alzheimer's disease has gradually ticked up to the point that now it exceeds $2.4 billion a year. So they've achieved that goal, and they've been able to take those recommendations and move them forward both through the federal government and then congressionally. Next slide. So that's it. It's a pretty straightforward process, I think, and hopefully I presented it that way, but I'd be happy to answer any questions. And again, I encourage you all to look at some of the NAPA recommendations, because there could be things in there that you would want to pull from, and places where they've successfully moved forward work in the caregiver support space that you all could build on as well.
Thank you, Helen. I wanted to throw open the floor to the council members, either federal or non-federal members. If you had any specific questions for Helen, we really wanted to get her perspective on how we might move ahead, and to give you all some food for thought on the decision-making processes that you'll use. You know, for instance, you know, do we want 1 million recommendations, or, you know, a smaller, more compact set that are very targeted and focused? This is something that we would, you know, look at year over year. We really wanted this opportunity to begin getting you thinking about how this is going to work. So, questions for Helen? No questions?
This is Catherine Georges. Can you hear me?
Yes, we can hear you.
I just wanted to know from Helen, where does she see the intersection with this advisory council? I like what she said, but I guess I'm looking to, I saw the recommendations that they have made. Does she think there's anything that we can extract, that we can, I don't want to call it superimposing, but intersecting with our goals and what will be coming out today in the guiding principles? Or is that one of the outcomes you're looking for at the end of the virtual meeting?
And that, was that Dr. Georges?
Yes, sir, Catherine Georges.
Okay.
So from my perspective, I think there's a ton of places where this overlaps, because, and when we talk about caring for people with dementia, the very next word of our out of our mouths is and their caregivers. So we've done a lot of work in making sure that health systems are not only dementia friendly, but thinking about how the caregiver is included as part of the care team. When you think about what a high quality dementia care system is, it's including the caregiver as a care partner and making sure you're sharing information with the caregiver. On a research perspective, there is a Dementia Care and Services Research Summit that happened in 2017 and is happening again in March of this year, where we're talking about how we can improve research on dementia care and services to support people with dementia and their caregivers. And so the caregiving piece is very, very important there as well, figuring out how the things that we're doing help people with dementia, but also help their caregivers. And we've always had a caregiver voice at the table for those meetings and at those summits. And we have open mics and caregivers provide input there as well. I mean, I can think of many, many areas where the caregiver work has moved forward because of NAPA generally, and then specifically related to dementia caregiving. But in a lot of ways, when we think about caring for people with dementia or any type of cognitive impairment, the vulnerabilities and the need for assistance and the need for support and the duration and intensity of support are among the highest. And so I think a lot of the issues that caregivers in general face are even more magnified among people who are caring for this type of population. So enhancing the aging network, for example, has been a recommendation, increasing funding to the aging network, making sure the aging network can meet the needs of people with dementia. There's quite a few places, and I'd be happy if you guys were interested and we could talk about drawing some parallels or identifying places where the Advisory Council on Alzheimer's has done work that might be useful to what you're doing, because I think it would be a shame to not build off of the NAPA work in the RAISE work.
And one thing that's important to remember that in the synthesis of recommendations that NASHP pulled together for the council earlier, all of the NAPA recommendations are in there. And so we have those to begin referring to. And I would like to just build on what Helen said about the strong connections that we see between the work of the NAPA Council and the Family Caregiving Advisory Council. For example, one of the recommendations that came out of the NAPA Council was that our Alzheimer's disease programs may want to expand their reach and focus to persons with intellectual and developmental disabilities who have early onset dementia. And so it was from that recommendation that we began to expand the focus and the reach of our Alzheimer's disease, our ADPI program, to include specific areas of focus on that population. So I think we have many, many opportunities to look for these close connections between the work of NAPA and the work that we're doing. Any other questions for Helen? Any other observations from the council members that they'd like to make?
Yeah, Greg, this is Alan. First of all, Carol Zernial is having trouble getting on, but I sent her a link, so she should hopefully be on soon.
Okay.
And then to Dr. Lamont, a question that is rather obtuse. It seems as though it's very important that we have the recommendations done in the right way. But right now we're working on principles and goals. And I'm wondering if there's a formula, for the lack of a better word, of build your goals this way to help them naturally lead into your recommendations. Or does he have any just general advice about how we need to be thinking about recommendations now, even though we're working on these very global issues and principles and goals?
Well, that is a great segue, because Bruce Fink, my colleague, is going to present tomorrow on the driver diagram process. So essentially what that does is go from those very high level goals that you're trying to achieve, and then what do you need to do to achieve those goals. And as you go through that process, you can figure out, what needs to happen. And with NAPA, when we brought in the driver diagram, we already had what was happening underway. But by using the driver diagram, we were able to see where there were gaps. And so we took advantage of that framework to identify where the next set of recommendations should be. So where have we kind of moved things forward? And it seemed like we were doing a lot, but if we were trying to ultimately get to our goal, where were there gaps? So I think that Bruce will talk a little bit about that tomorrow, and you can think about this. This is a little bit more downstream from what you're doing, but as you think about your work, this is the place where you sort of start the ball rolling to achieve those goals.
Thank you.
Thank you.
Any other questions for Helen? Okay, well, Helen, I've said it a million times, but we're so fortunate to have you working with us on this council and bringing your expertise. And I just appreciate you so much for the guidance that you've given to me and to Wendy at NASHB as we've worked. So we really appreciate that. Let's go ahead and see if we can stay on track. We want to jump into the first exercise that was given to you all in your prep guide, and that is taking a look at the guiding principles that we have. And I'm going to turn to our council member and co-chair, Dr. Casey Shillem, to take all of you through a discussion about what do we want to adopt as our guiding principles. We've tried to provide you with what we hope would be a very, very good starting point for those that hopefully could lead to an adoption of those in some form this afternoon. But I'm going to turn it over to Casey to lead us through that discussion. Casey?
Wonderful. Thank you, Greg. I just want to first confirm that everyone can hear me. Okay, great. Thank you. So thank you for the invitation to facilitate this part of our conversation today. I just wanted to orient everyone to a process for everyone to give and receive the feedback collectively. We have a large group of people. So I just wanted to point your attention first to the email that was sent on Tuesday, February 4th that had the agenda as well as our council member preparation guide. And that's what we're going to be working from today in terms of the questions that we'll be asking for feedback. And the way that I'm going to guide my section here that I'm working on today is to welcome people to use the chat function that is, if you are online, I've got the chat function open, so I'm able to monitor what people are typing into that chat function, as well as if you're on the phone and not able to chat, please know that we'll make space for people to be able to give feedback verbally as well. But I just wanted to let you know that I'm going to be able to monitor both of those options. And really, our first step today is to come to consensus on what we see as the guiding principles for how we are doing our work together. In the preparation guide, there were some guiding principles that helped with a framework for how to wrap our heads around the complexity of this work. So pulling from NAPA again, but also from the California Task Force on Family Caregiving, there were some ideas that were founded in the guiding principles, but what I've really appreciated about the synthesis of what I see in this draft of the guiding principles, and this is still a draft. Today, our goal is to try to get to that consensus that yes, we adopt these as our guiding principles. But I see that the terms and the phrases that we all shared when we were in our face-to-face meeting about what was important to all of us, it feels to me as though they are reflected in the words that are on the guiding principles that we currently have. So I know that everyone can read, so I'm not going to read them all to you, but just a few of the highlights that I wanted to point out that I think we're very grateful to NAPA for the foundation. And this kind of goes back to what I'm perceiving as the intersection of our two different groups doing this work simultaneously, is that the work on dementia caregiving has a really strong framework, but that we're taking it to all family caregivers. So we're able to build on that in a way that family caregiver is really inclusive and holistic in terms of a term for all who are providing care across the lifespan, across conditions, that we really look at focused on person-centered and family-centered care, that we're supporting autonomy, choice, and that we're recognizing that family caregivers are really trying to help with striving toward health equity in ways that we are honoring who they are as individuals, as well as the membership that they have in this dyad of a family caregiver, family care receiver, and that we are then able to collectively pool our wisdom into this living document that we see as important for moving forward with how we make recommendations, very similar to how Helen was describing the work that they've done. So I just wanted to orient us all to that as our first goal that we have collectively today in terms of getting feedback on the guiding principles. And I'm going to guide us through each question one at a time that we had for our assignments. And so the first question I'll pose is, do you feel that these principles are applicable and that they are relevant for the purpose of the Family Caregiving Advisory Council? And so I will open it up for responses back from everyone. And again, as I said, please feel free to enter in the chat function if you would like to use that as an option, or please feel free to share your thoughts on the phone.
Okay, I'll speak up. This is Ben Bledsoe. I mean, I found them to be appropriate. They fit well with what we had been discussing, and so I don't have much of a comment beyond support for adopting these. They seemed like they were well in line with what we've been discussing.
Great, thank you, Ben. I appreciate that feedback. It's helpful to know if we're on the mark too. So I'm also getting some chat function that is saying that that our members feel that they are clear, that they are applicable. Are there any pieces in terms of the clarity or applicability that you feel need to be enhanced, clarified further?
This is Rhonda Montgomery, and I really think that we need to add something to the third one, which it reads now, efforts to support family caregivers should, you have further, what I would say would further the autonomy, choice, and ability. It wasn't clear to me what individuals meant, and I think we need to clarify and say of both the caregiver and the care receiver. But we have to acknowledge that the challenge of simultaneously supporting both individuals, because sometimes they may be in conflict.
Mm-hmm. Really important point, Rhonda. So thank you for sharing that. So I'm hearing that your recommendation might be to change the wording such that it says efforts to support family caregivers should further the autonomy, choice, and ability
of both
the caregiver and care receiver to engage meaningfully in their communities.
Right, but I think we need a tagline that also acknowledges that that effort has to acknowledge the challenge of simultaneously meeting the needs of both people. That remains very difficult.
So perhaps we could say something like the efforts to support family caregivers should further the autonomy, choice, and ability of both the caregiver and care receiver to engage meaningfully, because then we're at least saying we have to acknowledge that there are two separate individuals for whom we are trying to support.
Yeah, and what we might say is add on that any recommendations we make are made. I mean, I just say we have to keep in mind that we can't always simultaneously meet the needs of both people. And that is a challenge, and we need to acknowledge that.
So maybe we say that, acknowledging the challenge of sometimes conflicting perspectives.
Yes.
Casey, this is James Cheeley.
Hi, James.
Hi. Sometimes it's hard to know what somebody else means when they write something down. So I'm going to ask the question to see if I can just figure out what you mean. As a guiding principle, I would presume that is what we base all of our recommendations off of as we consider making those. Is there a section in these principles that relates to what financial condition it places on a caregiver based on the recommendations we present?
So my recollection and understanding of how we're working through this is that the guiding principles are the ideals that we have in terms of our philosophy of how we are doing our work and what we are keeping at the forefront of how we are doing our work. And that specific components such as the financial impact or the support that may come in terms of finance recommendations would be included in goals, priorities, and actual recommendations that we may make in the future. I think an important point that Helen made is that, sometimes we may make a recommendation that is unrealistic in the context of the time, but it's still important that it's out there. Whereas guiding principles are truly it's like our North Star. And so that's how I'm differentiating what the guiding principles will be versus what some of the specific goals that we have. And I think in the goals, if you see that that's where we have those 4 areas of high level goals, and then we're going to dig into what are the specific recommendations we may want to make, that the guiding principles are going to stay higher level. Again, that's our true north. That's what we're keeping in mind as we make specific recommendations.
I think I understand. I guess I also want to be sure that we don't put into place a recommendation that imposes more financial implications on family caregivers as we propose that recommendation. Maybe I'm overthinking it. I'm sorry.
Oh, no, I don't think that you are at all. I think that is an important point. And I think that that's another theme that I've been hearing in our subcommittee calls, that I'm hearing in our conversations that we continue to have, is that we are keeping in mind the financial impact of any recommendation that is made.
And this is Greg, if I could add, I think it would be not only the financial impact to families and family caregivers, but also, what would be the fiscal impact on programs and services that would attempt to support those families? There, I think we have to look at both things.
Just a couple of pieces of information that's being shared in our chat function right now. So again, a few pieces that are saying that they're clear, simple, and comprehensive. Wondering on number 4, would we want a more holistic approach where we're also talking about the financial equity and opportunities for caregivers and non-caregivers? That absolutely could be a place where I think we might, from what I'm hearing, we could consider putting that financial impact in guiding principle number 4, to include something about recommendations recognize and support family caregivers for health equity in a manner that respects and appreciates their complexity, diversity, and perhaps we put financial impact and dignity so that it is right there. What are your thoughts about including that financial impact or financial equity component into the guiding principle of number 4?
It's James again. Just because I asked the question doesn't make it right. I just got to ask if I'm thinking about it.
Oh yeah, no, but others are commenting on that in the chat as well. And so you're absolutely not alone. And if this is our guiding principles, or if this is our set of guiding principles, and that theme of financial impact continues to come to the forefront of the conversations that we're having, it feels like it's pretty important that we at least identify financial impact.
This is Rhonda Montgomery again. I'm thinking that makes sense to add the financial, but I think it might be, because I had kind of questioned, well, what does health equity mean? And perhaps we really want health equity and what am I going to say, and financial equity. So the financial goes in with the health equity.
Mm-hmm.
Does that make sense? Because it really is, I mean, there's financial equity in the sense of social equity. You know, we have a group that's assuming a great deal of responsibility.
Mm-hmm.
This is Catherine Georges. I'm a little perplexed by the use of the word equity, you know, and financial, because we're going to have to further measure that. If you're going to name it, you have to have something to measure it. What do we mean? I don't understand. I know what health equity may mean, and I've seen, you know, numbers of things, but what do we mean by financial equity? Are you going to assure me as a caregiver that I'm going to have financial equity in caring for somebody? Is this a principle? I'm just confused. So if somebody can get rid of my confusion, I'll be happy.
So Alicia, I appreciate that comment. I think that the financial impact is something that we can keep as a guiding principle versus financial equity, because we are not going to have financial equity in the work that we're doing, but we can take into account the financial impact. In terms of supporting family caregivers for striving for health equity, I think that we are able to make an impact on, and that we can keep that as a guiding principle. So those are my interpretations. I'm seeing a couple of other things in terms of the chat, in terms of being concerned about the use of financial equity, but being very comfortable with including the wording of financial impact.
This is Rosemary. Can you hear me?
Yes.
Okay, hi. I just quickly Googled equity, and one of the basic definitions is the quality of being fair and impartial. And I think that hopefully is one of the tenet of making that statement, that in whatever efforts that we are doing to recognize and support, that it is a fair across all races, ethnicities, the context and situation that the caregiver may find themselves. And the same thing around financial equity is that it's fair and just, and there's no impartiality in regards to people in different situations and settings.
Thank you. I appreciate that that perspective as well. And so are you recommending that we do include financial equity as a component here?
Yes, I was recommending that it would follow immediately after health. It could say recognize and support family caregivers for health and financial, ensuring health and financial equity.
Well, I think that we have to say strive for, because I don't know that we as a council will be able to ensure health and financial equity, but I think we can make recommendations that could move us toward health equity and financial equity. So I just want us to be cautious about what we're claiming we're hoping to do with our recommendations.
But going back, This is Rosemary, just going back to that term, just making sure that it's fair and impartial.
Fair
That's
and
what I was saying.
Yeah.
Right.
Okay. So I think that's really important. And so we can absolutely move toward making recommendations that are fair and impartial, that recognize need for striving toward health equity, financial equity, and appreciating complexity, diversity, and dignity.
Hi, this is Deborah from Maui, Deborah Stonewalls. I'm just wondering, since these are the guiding principles, could we simplify it instead of even adding health equity? Could we say recommendations should recognize and support family caregivers in a manner that respects and appreciates their complexity, diversity, and dignity? And I'm sorry, in between then, after caregivers, we could say in a fair and impartial manner that respects and appreciates complexity, diversity. Do we need to even say health equity, financial?
This is Rhonda Montgomery again, and I think that was part of my issue is I wasn't certain what health equity is either, so I kind of like Deborah's suggestion.
Great. So I am hearing that we could move toward guiding principle 4 being recommendations should recognize and support family caregivers in a fair and impartial manner that respects and appreciates their complexity, diversity, and dignity.
I just want to point out, this is Greg, how much does that rewording, and I like the rewording, but how closely does that get us back to what we already have in number 1, where we talk about, you know, being inclusive, holistic. Are we afraid of any duplication there, or are we talking about two mutually exclusive concepts here?
Yeah, I
fine if
understand
we
your
are.
question, but I see these as two different principles, that when we're talking about family caregiver as inclusive and holistic as a term, that we are identifying that we are looking at the broad spectrum of all definitions of who could be defined as a family caregiver, versus number 4 is that our recommendations that we make really are done in a way that respects how complex and diverse all of the family caregivers are, so that we're taking that definition of what a family caregiver is into account with what recommendations we specifically make.
That's fair enough. Thank you. Just wanted to make sure we had that out there and we're clear.
So we've kind of melded into the other 2 questions, but I just wanted to kind of keep us moving along. That are there additional principles that you think that we should include? Or do we feel, I mean, I really appreciated the comment about, you know, these are our principles. These are things that are guiding our decision making. So this isn't saying this is a laundry list of everything we must do or include, but rather this is what we should be using as our guiding North Star as we make recommendations. Is there anything that you feel is missing that must be included in here? And James, I want to go back to your question about the financial impact piece, because we've gone around putting that in and then taking it back out. And I just want to make sure, do we feel that that is an important piece that has to be explicitly stated somewhere in our guiding principles? Or do we feel that it's included in that language of complexity, diversity, and dignity?
This is James again. I'm sorry. This is James again. I can only speak for myself. As I look toward us as a body making a recommendation, I don't want us to make a recommendation that puts more of a burden on family caregivers because we made a recommendation. Mm-hmm. So I think that guides how we have to make recommendations, that we can't make the burden more complex. It needs to figure out how to make it easier, if that's the right word, through our recommendation. So for me, there's still that degree of guidance that don't do something that makes it worse.
So let me offer this as a possible solution for us. Number 4 guiding principle could read, recommendations should recognize and support family caregivers in a manner that is fair and impartial, comma, accounts for financial impact, comma, and respects and appreciates their complexity, diversity, and dignity. How does that feel?
This is Deborah Stonewalls. I like that, Casey.
Okay.
Casey, I hope you have that written down, because I mean,
I do.
Great, excellent, excellent. Because what we can do is we can take that and drop it in here at some later point.
Yep.
And then as we make that final.
Hi,
So,
this
go
is
ahead.
Alan.
Yeah,
Hi, Casey. Can I just say this is great conversation, and I think it applies also to the next exercise when we're talking about goals. So I was just going to cheer everybody on to remember these statements, because I think we can get some parallel language in the goals.
Absolutely. And there is a comment about questioning if there should be a 6th principle that includes engagement with family caregivers in the development of the strategic plan. So there's a proposal out for an additional guiding principle, and I'm taking this to mean that we are purposefully putting as a guiding principle that we are including caregivers as we develop strategic plans, recommendations. Oh, and sorry, there's also a question about including appropriate metrics and measures to track our progress. That has come up a couple of different times. Thank you, Teresa, for putting that up for me again. And so I think that in terms of guiding principles, the 2 other recommendations that we're possibly seeing are, one for a principle about engagement with family caregivers, and then 2, a recommendation about including metrics and measurement to track our progress. So let's take the first one. The first recommendation that was adding in a 6th principle to include engagement with family caregivers. What are our thoughts about that one?
This is Rhonda again. I think that's a great suggestion.
Alan thinks so too.
Okay. Yep, and I'm seeing quite a few things in terms of the chat function that ensuring that caregivers are partners in the development of the plans and recommendations.
Alicia supports.
Sorry, this is Deborah Stonewalls. I'm wondering if that could be incorporated into the guiding principle number 2.
Promote greater adoption of person and family-centered care. Puts the person and family as appropriate at the center of care teams in partnership with caregivers. Something like that, Deborah?
Well, I'm looking back for the wording that I saw a moment ago about the strategic planning process. So if they are at the center of care teams, we could say that includes the strategic planning process. And maybe I'm trying to be too.
I'm wondering, yeah, no, Deborah, I hear what you're saying, but I'm wondering if maybe we could include it in guiding principle 5, that the national strategy will be a living document with ongoing actions created in partnership with family caregivers to be taken by federal, state, and local governments. Is that an appropriate place to put it in there so that we actually have the words in partnership with family caregivers?
Yeah, I like that.
This is Rosemary. I like that as well.
Okay. And then the final recommendation we'll discuss is should we include something about tracking our progress, including metrics, measurement as a guiding principle?
This is Teresa. I didn't mean to track progress, but to just where we can to add and maybe we do this after a recommendation is proposed, and if we massage a recommendation, so that in one of the previous presentations, they said those that were more specific, recommendations that were more specific had better outcomes for implementation. And so if we, at some point, and so maybe it's not when we write the initial recommendation, but to include some kind of measures, and they could be high level measures in terms of, so that would enable us to track, but we don't have to have the measure that tracks, but just some kind of quantifiable measures.
I think that is a really important point, that we should be putting that into the process of how we make recommendations, is that we do include what are the metrics that we're wanting to follow in terms of being able to evaluate impact.
I agree, but I'm not sure it belongs in the guiding principles because of the fact that the recommendations actually going to be carried out by a variety of agencies, and they will all have their own kind of tracking mechanisms. So I think there's a place for it, but maybe not. Maybe we don't have to get into the details.
Right. Okay.
All right. Well, I will keep us on track and ask for any final comments from anyone. It feels as though we've made some really good progress. Oh, I'm also seeing a final comment here about valuing the lived experience of caregivers and care recipients, that our work will include and engage them in our planning and decision-making and implementation processes. Carol, I think that's another really important point. And I'm hoping that with putting that the national strategy is a living document done in partnership with family caregivers would be able to encompass all of those pieces.
So this is Greg. I want to keep things moving, and Casey, thank you for leading us through this great discussion. I'm wondering, do folks think we are, the non-federal members think we're ready to take a vote on our more or less wordsmith and revised set of guiding principles so that we can adopt them and move forward? If Casey were to read through each of the 5 again as we've edited them kind of in real time, we would have that then captured, and we could put it down in writing. You know, would folks be ready to take a vote on this, the non-federal members? We can push out a poll for that. Okay, so I see a couple of heads nodding. So Casey, do you want to read through the 5 as you have them revised, and we can then put it out there for a vote?
Yes, so I have guiding principle 1 remains the same. It is unchanged as it is on the slide of family caregiver is an inclusive and holistic term that includes all who are caring for individuals across the lifespan with chronic or other health conditions, disabilities, or functional limitations. Number 2, promoting greater adoption of person and family-centered care that puts the person and family at the center of care teams. Hold on just a moment. Acknowledging the challenge of possible conflicting goals is what I have. Number 3, efforts to support family caregivers should further the autonomy, choice, and ability of caregivers and care receivers to engage meaningfully in their communities. Number 4, recommendations should recognize and support family caregivers in a fair and impartial manner. Recommendations should recognize and support family caregivers in a fair and impartial manner, accounting for financial impact, and respects and appreciates their complexity, diversity, and dignity. And then number 5, the national strategy will be a living document with ongoing actions created in partnership with family caregivers to be taken by federal, state, and local governments, communities, providers, and others while fostering cross-discipline and cross-sector collaboration.
So given that, if we could push out a poll, Cheryl, and we can ask the non-federal members to take a vote. The question, I think, should be fairly straightforward as we constructed it. Hold on. Okay, so if each of the non-federal members could cast their vote, these will be recorded, and then we can we'll know the results of this first round of voting before we move on to the next section of the agenda. So Cheryl, are the votes coming in? Okay. All right. Are you able to show the results? Okay. It's very exciting. Yeah, so the technology is a little, here we go. So we have 100% agreement on these principles. What we'll do is we will revise them. So when we can tomorrow, when we convene, we can put up this put up the revised ones in our opening little recap of today. So thank you all very much. This is incredibly useful. And what we're going to do is we're just a little bit behind in the agenda, so I want to go ahead and turn to Alan Stevens and for him to lead us through the discussion about revising and expanding our current goals. So Alan, I'm going to turn it over to you.
Great, thank you, Greg. So similar to what Casey did, we were just going to review the work that we have done to date, but this time around the goals, and then we'll build upon after that review, we'll build upon that with the exercise that we all were asked to complete over the last few days. Can everybody hear me okay?
Yes.
I'm getting a message saying I need to unmute myself. I'm assuming that's not right. So back in our first meeting, I think it was on the second day, we started pulling together ideas that had been discussed and came up with initially 4 goals that were then reduced to 3 goals. And each of those goals has then formed the topic of the subcommittees that have been working nearly every month since last August. So just to review here, the goals as we adopted them in our first meeting. So, that's not to say that they're probably not perfect, but it captured where we all were in that first meeting. Goal 1, assist caregivers in optimizing care and support for their loved ones. And then for each of the goals, we also, in the small group discussions we had come up with some general concepts that we quickly labeled as priority areas. This again is subject to change. We were doing this kind of fast work, but I think we really caught or captured a lot of the main topics that were being discussed in the small groups, and that's reflected in the priorities. To be transparent here, we have not really said anything about the connection between how we're going to link the goal and how it's worded to the priority area. So that will be something else we'll want to talk about later today after we go through all of the goals first. If it's okay, I think I want to go through all the goals first, and then we'll come back and talk about them. Greg, you're nodding your head. Is that okay?
Yeah, that's absolutely fine.
And then goal 2. So goal 1, assisting the caregiver basically in their role of providing care. Goal 2, enable caregivers to provide care while maintaining their health and well-being. Goal 3, enhance public awareness, education, and engage non-governmental entities to support caregivers. And then 4, what we had discussed doing was something around improving data, tracking everything from surveillance data to actual outcome data. The group that was engaged in that really thought that that was probably more of a cross-cutting topic. And so it was put on hold until the first 3 goals were further delineated. Questions about the goals, and the next thing we'll do is go through each one of them. So you'll have time to answer questions, but is everybody okay with the general setup here? Is that everybody's memory of everybody on board? Great. It's because of your good work, Greg, and your team. So goal 1, let's open the floor up now for comments about everything from this theme as being one that should resonate to such a high level that it's a goal, and then is the wording correct and getting it right in terms of how things are worded to be inclusive of the large diverse group of individuals we have.
Did you, were you going to, Alan, go through the other slides that looked at it, took a deeper look at each one of the current goals, or did we want to go? It's up to you how we want to do this, one by one.
Yeah, I think, yeah, let's just get some initial conversations, because I do think there's some very, so if we could talk a little bit about this one now, is that okay?
Sure. Yeah, no, absolutely.
So let me throw something out here to get the conversation going. I'm not so sure about the term loved one in this. It's a term that's not always endorsed in dementia caregiving, because many times families will say, you know, I got to care for him, but I don't love him anymore, you know, and or can be offended by the idea that because their family member are being cared for, that they are loved. I don't know that that transcends the lifespan, but we do hear a good bit in aging.
This is Catherine Georges. Alan, I think you're right on target. There are people who take care of folks because of an obligation, not necessarily an emotional tie, and they are family members. And I would, whatever the word is, care recipient, whatever, something, and somebody who's good at wordsmithing can kind of, you know, grasp that. But I agree. I wouldn't use the word loved ones. I never do it when I, you know, refer to the recipient of care.
Yeah, and I see Rhonda saying that she agrees not the best term, that maybe care recipient is a term that is not perfect, but captures it. Or family member receiving care, care recipient. You know, you have a tendency to get too wordy here, but does the term care recipient resonate outside of healthcare and academia?
In the literature, normally you'll see care recipient.
Great.
And this is Greg. Not all care recipients would necessarily be family members. They could be informal friends or acquaintances as well. So,
do we want to say assist family caregivers?
This is Rhonda. I think that's not everybody's family, bottom line.
Rhonda, I'm sorry, this is James Cheeley. Rhonda, can you define what you meant by that?
Well, many care recipients may be not family members. They may be friends. They may not have a true legal relationship. There's quite a range. So I don't like just family.
Isn't that the group we're targeted to?
Yeah.
Well, we're targeted to the informal caregivers, which are mostly family, but not all.
But I think the term family is really referring to the caregiver as a member of society, a member of, you know, that's their role they're playing. It's not a direct link to the person they're caring for. It's more about their status. As a better word for informal, as you said. So I know informal is not well liked by a lot of people. Catherine, I understand AARP really doesn't like it.
Well, I really think care recipient goes the farthest distance to meeting the people we're talking about. I'm afraid that when we get into legalese and if we have goals for changing federal policy, the word family can become very problematic.
This is Lisa McGuire. I agree as well. I think, you know, we might mean family very broadly and you can pick your family, but I think it's going to have the legal implications and ramifications. We usually say family and friends because your neighbors, I would hope, are your friends as well too, and just people you know around town are hopefully your friends.
Okay, we have some comments coming in too. Let me clarify. So the first, I think, edit was to change loved ones to care recipients. And then the second issue was, should we insert the word family before caregivers earlier in the sentence? And I think that's where we don't have agreement, but we have agreement on care recipients, correct?
Oh, this is Rosemary. This is Rosemary. If we go back to our first guiding principle, we have family caregiver and a definition. So we need to be consistent throughout.
I mean, that is the name of our group.
This is Lisa, but especially in federal documents and any big document, things get used out of context too. So just because it's in guiding principles, I wouldn't assume people refer back to it. I think it needs to stand alone.
And this is Diane. And in that guiding principle, family caregivers in parentheses, in quotation marks, and then it goes on to describe that it's all who give that care. And so I think if we say family and friends for this goal would make more sense.
So back to the core issue, Lisa, let me specifically ask you, do you think we need terms that distinguish paid and non-paid caregivers or formal and informal caregiver, or you think that distinction's not needed?
We usually make a distinction in our work because if we don't make the distinction, somebody always asks us about paid caregivers. But then, of course, as you know, it gets stickier with some of the family and friend caregivers and some of the programs where sometimes they're getting paid or getting some of the CMS benefits. So it's messy. Sorry, Alan, I'm not going to give you a clean cut answer, but I mean, what we're trying to say is they're not working at the assisted living down the street and getting paid to provide that care. They're still helping a family or friend who they might be receiving some token or some bit of funding or something from them for that service.
So this is Helen. We had to deal with this with Alzheimer's disease in the NAPA legislation, and you'll notice it's called NAPA and not NAPA because it doesn't say dementia, it says Alzheimer's disease, but really we're talking about all Alzheimer's disease and related dementias. So what we wound up doing at our kickoff at the beginning was we just went with what was in the legislation and set up front in any documents that we put out that throughout this we're going to define Alzheimer's disease as Alzheimer's disease and related dementias as per the legislation where it defines it like this. So one approach you could consider making would be to say we're going to talk throughout our work about family caregivers, but when we talk about family caregivers, we mean an adult family member or other individual who has a significant relationship with and who provides a broad range of assistance. You go through the whole definition from the legislation up front and then not have to pick the perfect term right now and give it a little bit of time and see if you've come up with something else.
Yeah, there is language in the research literature that takes the word family and then does a phrase behind it to say this is inclusive of da 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 da. In the interest of time, Greg, can we defer that back to your office to come back with some options on based upon the literature? Just that.
Sure.
20 minutes into this, I don't want to.
Sure. This is Greg, and so I pulled up the RAISE Act, and there is a definition there of family caregiver, and it says the term family caregiver, which is in quotes, means an adult family member or other individual who has a significant relationship with and who provides a broad range of assistance to an individual with a chronic or other health condition, disability, or functional limitation. So that the term family caregiver is defined, it's how it's used in the Act. And that's our guiding framework, at least.
So we can take care of that either in the preface or somewhere.
Sure.
Okay.
Can I ask one question on that?
Sure.
There are a number of not adult caregivers. You know, what do we do with our teenagers who are doing care? How do they fit there?
Yeah, I mean, while the RAISE Act is specific about adult family member, I mean, we do intend this to be lifespan in its approach. And so we could certainly, I think, as long as we're inclusive of everything in the RAISE Act, if you all choose to, we could expand it a bit to make sure that we're talking about all caregivers.
Okay. Other thoughts here on goal 1?
This is Rosemary. Can I get a little bit of clarity in regards to priority number 2 on incentivize?
Sure. We haven't, we can go back. We hadn't talked about that at all. It's just so if everyone's okay with the opening statement, we can talk about the priorities. So go ahead, Rosemary.
Just wanted clarity on what was meant by incentivize and support workforce development. I
don't have those notes, so I'm sorry. I don't.
Yeah, I'm not sure. I mean, when we talk about incentivizing it, this is Greg again, it could mean anything from, grants to support that, the development of workforce in this area to, employment programs. I think, I'm not sure that we had a clear definition of what incentivize means.
I have another question about that, and I'm not sure what I'm going to say fits under goal 1 or goal 2. But what seems to be absent is any addressing of incentivizing healthcare systems or insurance systems to create protocols to identify caregivers and give them and create services. We haven't, in none of these goals, they all address doing something, but they don't address healthcare systems and insurance systems, which really do control. And what I'm bringing up may go under number 2, not number 1.
Or could it be its own new goal? Remember, we don't want to necessarily limit ourselves to these 3 or 4 draft goals that we have. We may want to scrap one of these or both or 2 of them and come up with a whole other set of them. This is really the purpose of this exercise, is that given the discussions that the subcommittees have had over the past several months, is really visiting these goals, revisiting them, and then determining what works best for us. And a little bit later on in these slides, we had provided an example of a set of goals that we found that the National Alliance for Caregiving has been using or has put forth that may actually help inform some of the discussion that we may choose to do a hybrid of something that we developed here in our first meeting in August, but also looking to what other groups and organizations have done in this area as well. So I throw that out there just for some food for thought.
Thank you, Greg. I really do think that there's something missing, and I don't know if it's a goal or a priority, but I don't see how we can do this kind of support without incentivizing healthcare systems and insurance systems that control how these things get paid for. We need something about that.
Okay.
Great. While we're still on this, can I go back and also talk about the word assist? Is that the right word? It's hard to define, but I know we generally have to have some leeway here. But this was kind of part of the question that what I was asking Helen earlier was, how do you write goals so that they support recommendations? And again, I have no idea, but which way you go. But instead of assist caregivers, it could be something like ensure caregivers have support to, I don't know. Maybe I'm just going off in a bad way here.
How about something like this, Alan? Caregivers have the care and support they need for their loved ones. Something that's aspirational. Could be, it could be easily measured, or maybe, I don't want to say easily, it could be measured, and it has a way to establish a baseline.
I like that person-centered approach of, we don't know what everybody needs, but that's our goal, is that everyone has a very person-centered approach to get this care and the support they need.
Can we change the word assist to enable? Enable caregivers to optimize care and support for their loved ones.
Yeah, that's good too. Greg, I haven't been getting all of these notes down, so I'm hoping somebody is. So, Greg, I'm going to go to you for our time check here. We're 30 minutes into this.
We've got about
all of this and come synthesize it and bring it back. I don't think we're going to take a vote on ours today.
Right. We have another 40 minutes for this portion of the agenda.
Okay.
So we're in good shape. I mean, we could certainly move through a couple of the others. And what I would also like to do, if you could, is show folks the set of goals that the National Alliance for Caregiving had come up with, because there may be some things in there that we can learn from and draw on that would inform the discussion.
Okay, great. I'm sorry, I didn't realize that was the order. So do you know more about this slide than I do? Would you mind talking about this?
Sure. I'm going to turn to Wendy at NASHB, who found this and can give a little bit of an overview.
Sure. So this just came straight from the website of the advocacy goals from the National Alliance for Caregiving. We thought you might want to take a look at this because there are certain items in here that we know you have brought up during your subcommittees that weren't necessarily in the initial set of goals. So for example, financial security or financial well-being, I know has come up in discussions that is very important. In fact, in the earlier discussion today, financial impact again came up. And so we wanted to kind of point that out to you. Is that something, and I don't think we have to wordsmith right now, but just as a concept, do you feel that should be a standalone goal, or is something to point out? Do you want to mention very, very specifically, again, kind of going back to Helen's comments of, you know, how specific do we want to be? Do you want to, at that first bullet, expand access? Do you want to say something about services and supports? I know in the RAISE Act, they talk about services and supports as well as respite care. So again, how specific, do you want to be a little bit more specific on the goals? And then again, coming up with this concept, I know in the initial meeting, that fourth goal, we kind of listed it, but then didn't act upon it. Do you want to build that out some? And again, I know that came up as a potential principle, but then we didn't quite adopt it, thinking we could bring it in a little later. Would you want to make that a goal? Something around data and research and evidence-based practices. Here are just some ideas on a slide to give you some ideas to see, are those some goals that you again would want to add to what you have, or modify what you have so that you can call out it a little bit more specifically. So I leave that with you for further discussion.
This is Rosemary. One thing that I think we need to be to ensure is whatever the RAISE Act says that will be provided, that those are part of the goals.
Yeah, and this is Joe Caldwell, and I would echo that. I actually really like these National Alliance for Caregiving goals, and I think they do line up better with the requirements in the RAISE Act. You know, and I don't know, I guess I'm not saying we ditch our previous goals, but I was having a hard time aligning what was in the RAISE Act with the goals, because a lot of times they would go into goal 1 or goal 2. So the way that we have it divided up, I was struggling with where do you put things. And I think this framework to me is easier for me to understand where things go.
I have similar thoughts, Joe. I don't know exactly how to do it, but after reading these, I thought that ours seemed rather combining. Talk about the caregiver in this way, and let's talk about the caregiver in this way, as opposed to this was more practically based rather than role based. That makes any sense?
Alan, this is James Cheeley. For my 2 cents worth, I really like bullet number 4 on this slide, including caregivers as members. I think so often somebody makes a decision and says, now you have to live with it. And there's no, what do you think about it before we make a decision? We can be honest and say you probably don't really get much of a seat at the table, but to at least think you had an opportunity to have a seat at the table is better than to not be included at all.
Right.
Alan, this is Rhonda. I just sent you a text for goal 4 that also kind of addresses that 4th issue.
I thought it was wonderful.
If you want to share that, see what folks think.
Okay.
And Alan, while you're pulling that up, this is Carol Zernial. I'm wondering if we have room, if you look at the United Nations human rights, then you see that people have the right to actually health, income, but they also have the right to education, leisure. And so I'm wondering if, along with these very specific goals, if we want to refer something that says caregivers should have basic human rights.
Yeah, I'm sorry, I was doing that. That's a heavy question. And I was doing something else. What does the group think about that? And let me get this message out to everyone.
Do you want me to just read this and make it easy, Ellen?
Yeah, no, I've got it right now.
Okay.
I think I do.
This is Deborah Stonewalls. Rhonda, you did send it to all panelists.
Oh, okay, good.
Yeah.
It just went out again too.
Okay. Thank you, Deborah.
So Carol, can you repeat that again? The key phrase of human, go ahead.
Yeah, I'd be happy to send something in writing, but in thinking about we talk about health and we talk about income, but we don't talk about the other human rights, which are education and the right to leisure. So I'm wondering if we want to look at those domains to make sure that our goals align with basic human rights as adopted by the United Nations, including the United States.
I think it's on the surface, it sounds like maybe it doesn't really apply, but when you say things like leisure time and pleasure, that's one of the things that caregivers suffer the most from, So,
and we talk about the need for respite, and respite relates back to the need for leisure time.
Right.
Alan, this is Nancy.
Hi, Nancy.
Hi, I was having trouble with my microphone. I really like the National Alliance for Caregiving goals. They read in a more simple way than some of the goals that we've started with. And I think one of the things we need to do in our writing is to keep things as simple as possible for everybody who's going to read this document. But the one that, and I agree with James about including caregivers as members, as actually decision makers when it comes to health and human services systems. But I also like the protecting financial security of caregivers. I don't know if I want to say protect, we might want to say enhance, but I think financial security, there's so much that goes into that should be a standalone goal.
Thanks. I think that's another good comment. Another issue that I was kind of having with our original goals is that they tend to only have the caregiver as the actor. It's the caregiver providing care, the caregiver arranging care. And I know it's not in all cases, but in some cases, that's a dual or interactive relationship with the caregiver working with the care recipient to establish, the best care. And I thought that idea of some mutual, some activities that would be mutually beneficial to both the person receiving care and the caregiver, so that together as a unit, they receive the best care that was needed. That maybe is too nuanced, but if we go in another direction, like on the screen now, that's an easy thing to throw in and a description of how care is done.
This is Greg. Would that speak to the whole concept of the dyad in caregiving, that relationship between the caregiver and care recipient?
Yeah, I mean, it kind of goes like, that some people don't want care recipient anymore. They want them called care partners. Mm-hmm. That aspect of sometimes, is this a arrangement that's a care partnership, or is it strictly a one direction caregiver doing everything for the care recipient? Which our current goals don't address this kind of potential of a care partner approach.
Right. I will say the one thing that struck me about these examples that we're looking at from the National Alliance for Caregiving is that I could sit there and actually start to come up with action steps and drivers that could actually help get us to there, which will be part of our exercise tomorrow. I found it easier to come up with action-oriented statements that, different, federal agencies could do, states could do, communities could do, that really speaks to all of the levels that the national strategy has to address. You could begin to think of actions that could be taken at all of those levels that address each of these goals. And I think we want to try to make our goal statements as simple and as actionable as possible, because that's going to, I think, provide greater clarity in the end.
Okay. So let me just do a status check here. We kind of did a deep dive on our first goal. Then we came to look at these, and there seems to be a lot of enthusiasm around, or at least some interest around how these are worded. What's the group's feeling about what do we do now? Do we want to go back and look at the other two goals briefly first, or do we want to move towards this type of wording?
Alan, this is Nancy again, and Greg. Is there anything in the RAISE Act that would not be covered in one of these 5 goals? Are we missing any major point?
I don't believe so. I'm going to go pull it up really quickly. I can skim through it, but I believe that these hit many, if not all, of the basics in the RAISE Act.
Okay.
This is Rosemary. I could read them quickly if you would like.
Sure.
Number 1, promoting greater adoption of person and family-centered care in all health and long-term services and support settings, with the person receiving services and supports and the family caregiver as appropriate at the center of care teams. Assessment and service planning, including care transitions and coordination involving family caregivers and care recipients. Information, education, training, support, referrals, and care coordination, including with respect to hospice care, palliative care, and advanced planning services. Number 4, respite options. Number 5, financial security and workplace issues. Number 6, delivering services based on the performance, mission, and the purpose of a program while eliminating redundancies. And then it goes into some other aspects.
Right. So as I read that, typically how I would read a piece of legislation, I think the basic goals that the Alliance has come up with, I would say address about 90% of what Rosemary just listed off. I think there's an opportunity with that final one about delivering services based on performance, was it mission, and the purpose of the program. That certainly speaks to the organizational structure in which programs and services are delivered, which could speak to publicly funded programs, private programs. It gets somewhat to that performance measurement, as well as the data gathering, evaluation, of programs. So, I mean, that right there could be actually the basis for perhaps a 6th goal, if we wanted, that would look very specifically at systems.
Alan, this is Nancy again. I'm wondering if the last bullet, if we should say enhance the health and wellness of caregivers and care receivers, because some of the RAISE Act goals specifically mention care receivers or recipients.
Good point. It's kind of often hard to say with so many of these people having, chronic conditions that are naturally going to decline. Maybe not enhance, but somehow attend to. I'm just a little worried about using the word enhanced.
what is it? How about effectively address the health and wellness needs of caregivers and care recipients, or maybe not effective, but
I think it's like care recipients need to have the best I can do right now quickly is to say the appropriate level of quality care that they need, because of the diversity of that, what we're dealing with, the lifespan and a variety of diseases. It's
yeah, we have one suggestion for support the health and wellness of caregivers. What do folks think of that? Yeah, to the maximum extent practical.
This is Rosemary. Could you just not take number 2, which states assessment and service planning, including care transition and coordination involving family caregivers and care recipients?
You said not take it, so
Add it as a 5th or 6th goal.
I think that may be too long.
So ensure assessment and service planning, or support assessment and service planning involving family caregivers and care recipients.
mm-hmm. You could almost make a case for combining 2 and 3, since assessment and service planning lead to the provision of services, or are part and parcel of the service delivery process. You want to have them connected somehow.
That just sounds more bureaucratic than health and wellness.
Yeah.
Well, no, the assessment and service planning is related to when a family caregiver and a care recipient are actually receiving guidance around discharge planning, what types of services are going to need to be provided within the community, versus the health and wellness of the caregiver is more around respite options, other health and wellness opportunities, whether it's, physical fitness, counseling services. That's what I thought that statement was in regards to.
So maybe we separate those 2 ideas.
This is Catherine. To me, they're so intertwined. Maybe as we look at the wording, we're then very specific in later on someplace in defining some of what we mean. But, a goal is broad. I think we don't want to, I know this is a federal advisory council, but I'm with Nancy. We just need to stay away from some of that language that immerses us in what the folks outside will think is bureaucratic jargon. So that's just a comment.
okay. So we've got a lot of options on the table.
Yes, we do. This took a direction I wasn't anticipating, which is actually good.
I was not in the way we anticipated, but very, very fruitful. But I think we might need some time to kind of regroup this and bring all of this back to the group for a second review.
Which we could easily do tomorrow. We can, what Wendy and I can do here is begin to synthesize what we heard on the call today. Looking at the goals we sort of adopted in August, with some variation or version of these goals that the National Alliance for Caregiving has articulated, and then cross that over with the RAISE Act, and perhaps craft a set of maybe 5 to 6 broad, very simple but actionable goals, and then present that to the group tomorrow to take a look at.
How does the group feel about that idea?
This is Rhonda. I think it's a good idea, and I'm also suggesting that maybe the goals can be simple, but the detail can be in the priorities.
Good.
Exactly. The details can be in the priorities and in the action steps underneath those.
And there may be some similarity in priorities across goals to get at these kind of thread issues that apply to more than one goal. We did also, in addition to what we've done thus far, which has been pretty much based upon the old goals and then these, people were also asked to bring forward any new goals that you might want to add. Anyone have anything that we haven't discussed yet? Okay. So.
Well, Alan, I did suggest that the one is a goal, but as I'm looking at it, it may be a priority. But I do want to make sure that we're really addressing, everything's kind of addressed to what we do to the caregiver, but this is systematic. So what I had written is incentivize healthcare providers and insurers, public and private, to create protocols to identify caregivers and services and programs to support them as key members of the care team. And that may be a priority.
I do. I love that statement in general. I think is so necessary with the work that we need to do. That yeah, it may be something that is seen more than once, becomes a priority.
I think we actually had in the preparation guide pointed out where some of these priorities definitely are cross-cutting and could appear in more than one goal. So
right.
I think that's definitely something that we can.
Because, you know, whether you're talking about the health of the caregiver or the care recipient, if it's for the care recipient, there's a need for new models of care that do better care integration, better engagement of the caregiver. That's an approach that's important, but so is an approach in which a healthcare system sees a caregiver as an independent person with their own set of goals and health needs and treats that person within the context of their care, of their role as being a caregiver. So those are two, I think, critically needed aspects, but I think healthcare systems would come about it, and even providers and payers would have to come about that from two vastly different approaches.
This is Rosemary. Does there need to be something in regards to diversity and inclusion, especially around the legal aspects of being a caregiver in our complex world of what a family, quote, is, and having the ability to have access to care recipient information, being able to make decisions about the welfare of the care recipient?
This is Greg. I mean, we do in our guiding principles, we do speak to the issue of ensuring that everything we do is reflective of the diversity of the family caregiving experience, and that recommendations and policy recommendations that are put forward are inclusive of that diversity. So I don't know if that gets to your question, or if we want to be a bit more specific.
This is Catherine Georges again. A Rosemary question about it being clearly stated on a federal level. But there are states where, I'm not bragging about AARP, but there are states where we have gotten the acts passed in those states that addresses some of the issues that Rosemary just brought up about whomever the patient is, they identify who their caregiver is. And then the institution is obligated to give that information to the person defined as the caregiver. And it could be a family member, it doesn't have to be, it could be a significant other. But I don't know how these two, go together, Greg. You're the experts on the Fed stuff. So, but I do want you to know that there are already state efforts to address some of what Rosemary said.
Okay, thank you.
This is James Cheeley. Dr. Georges, if you don't brag on the AARP and what you're passionate about, I would be disappointed.
Thanks.
We really haven't talked about the data. I don't think we've talked much about improving data and tracking progress. Maybe we got enough on the table for now, Greg, or do you think we need to?
We may have enough, and as Wendy and I take a look at this this afternoon, we may want to include something as a suggestion that's more or less overarching in terms of how are we going to monitor the progress that we make towards these goals and objectives. That may be something we want to weave in as opposed to having something as standalone, but that we can take a look at that for sure.
This is Teresa. Would we want to consider a goal that somehow promotes solution collaboration? Is that something?
What can you define that a little bit?
Yeah, I could do like sub goals that would fall under it. If from reading the act, it seems as though it's intended to support the well-being for the family caregivers, to provide comprehensive solutions that help the delivery of services to the care recipient, basically. But the solutions, we're not going to be able to provide to implement all the recommendations, but that supports the collaboration where any entity, public or other communities or state governments could then pick up those recommendations. I understand where the recommendations are, what the outstanding recommendations are, so then they can take a specific recommendation and proceed with implementation of that. So collaboration between government agencies, between government and stakeholders. Other types of, under that would be like web portals. It could be data metrics too, because if we identify recommendations and define what the success criteria is, then we're basically setting, this is how it's successful, and somebody then can, if that's a model that is intended by this, because there's a lot of collaboration for states and governments and communities. So I didn't know if we needed to do something in that respect.
What you're saying is very, we need to consider that, and I'm almost wondering if that would come later once we establish these goals that are very specific and measurable, that then underneath some or all of them, we look at the opportunities for this solution collaboration that you mentioned. Who are the necessary partners to be involved in that, in making that goal or that a part of that goal realized. I think that's maybe not a goal in of itself, but it's a common strategy or an action that would be part and parcel of many of the goals.
Okay, yeah.
Hey, Greg, this is Joe Caldwell. Something that might be helpful if we go with something along the lines of the National Alliance for Caregiving goals, or come up with those 5 goals. I think looking at the synthesis that NASHP did, that they identified like 12 areas from all those other reports, and I think those are gonna. I think when we get the comments from the public, I think a lot of them are gonna align with those 12 areas. So, maybe looking again at that document and seeing if some of those might be the priorities that go under
the goals,
5 bigger goals.
Yeah.
Because I thought that that synthesis document was really helpful.
Okay.
Joe, that's a great point. I was getting to that point too, of thinking we're doing a lot of good work here, but we've got 1,800 comments that we need to make sure are represented in these goals. Okay, Greg, we're almost out of time. Well, I had us going to 3:30. Do we go to 3:40 or do we?
Yeah, about 3:40, but Wendy wanted to weigh in. So go ahead, Wendy.
Do we need to do the driver component during this time, or is that?
No, that's tomorrow.
Okay.
This is Wendy with NASHB. I really like that a lot. And so I think what Greg and I can do is take some of these goals and do just what you suggest, both of you just suggested, where we take those 12 items and then we see where they fall under each of these. And then we can do another slide so that when you all come back, you can exactly see what the goal and then the priorities would be underneath. And then that way you all can then see if you need to add more, take out, reword. So just, Alan, I know you're shaking your head. You think it's a good idea. Do others think that that would be helpful? Since we have a lot of different, I've written a lot of notes. Maybe if we get all those together, we can take another crack at it again tomorrow.
Wendy, this is Nancy. I think that would be helpful, but I also want us to keep in mind that tomorrow we're going to be asked to come up with drivers for each of the goals, which is why I keep coming back to let's keep this as simple as we can if we have to attach drivers to these goals.
And that's what Wendy and I will try to do, is to make these, somebody typed into the comments, and this was a really great reminder about what SMART goals are. And SMART is this acronym for specific, measurable, achievable, realistic, and time-bound. And I think that with that in mind, Wendy and I could probably take the feedback that we received today along with the National Alliance goals, our goals from August, and the synthesis document, and probably come up with 5 or 6 fairly simple goal statements that kind of meet that SMART acronym, and share them with you tomorrow. You know, we can make tomorrow's agenda a little bit more flexible in terms of, you know, maybe using a little bit of the time right at 1 o'clock to revisit what Wendy and I come up with between now and tomorrow at 1, and then go into a discussion of how the driver diagram would work, and then use whatever time we have left to begin identifying some drivers under each. It may compress our time frame a little bit tomorrow, but I think we would probably be able to make a bit better progress if Wendy and I spent some time thinking through this. What does everyone think about that?
That sounds good. I'm glad you brought up SMART goals. I kind of thought we had thrown that out of the window. So I'm glad, because our goals currently aren't very smart. But I think we can come back around to that now and make them better. Just one comment that I'm sure everyone is on the same page, but just to make it clear, we do want to make sure that our goals are unique from any other group. Now, I think there can be considerable overlap, but you know, I don't want to just adopt somebody else's goals.
Exactly, and I think that should be, and I think that was our intent as well. I think we have a great start here, and it was very helpful to listen to this discussion and to get a sense for where everyone's head is at around this, and we can take a stab at something that's truly unique for this group, reflective of the requirements of the RAISE Act, and move forward from there.
Greg, this is Helen. Can I just say one thing? Because
sure.
On the other side of this recommendation, or this advisory committee making these goals part, is you and ACL and federal partners writing a national strategy. So we also have to think about how and where there are places that the federal government could make commitments to in a federal strategy, and where there are places where, and other governments, where it might not be feasible to do something. So something like financial support or ensuring the financial stability of caregivers might require congressional action, which would be amazing and important, but it might not be something that the federal government could or would have federal policy levers on at this point and could commit to for a strategy. So it's just a sensitivity and a balance of being both aspirational, but recognizing that at some point we're going to have to write a strategy that's going to have actions we've committed to that we know that we can do, and there will have to be a balance there between those two pieces. Does that make sense?
Yeah, that makes total sense. Thank you for sharing that, because that is, that needs to be, particularly for our federal partners, will be front and center, but it also, is important for, our non-federal partners and others to understand the limitations that may be at play.
This is Rosemary. I think Dr. Dr. Helen Lamont, her presentation on NASB, I was listening pretty closely to the section where she discussed the role of the federal partners and how they identified the actions that would require congressional, support or legislation, and being able to sort of tease those out before any of this information is released to a broader audience.
Exactly. Yep. And that's why we're, so grateful for the inclusion of our federal partners on this, because it'll definitely make it more doable. Okay.
This has been a great session, but very active. Can we just go around quickly? Anybody have any comments they didn't have a chance to get put in earlier? Last call. Great. All right, Greg and Wendy, y'all have a pretty significant overnight job to do. So
yeah, thanks. No, this is good. We certainly appreciate the discussion. So it looks like
I think this can be an iterative event, process.
Oh, this whole process is going to be iterative. I don't even think that once if we're fortunate enough to come to consensus on a set of goals tomorrow, I'm not so sure that there wouldn't be some shifting of those goals as we move down the line. So we just need to be able to establish a framework to jump off from. And so that will be what our goal is tomorrow. So as for tomorrow, we had planned to jump right into a discussion about the driver diagram process. We may need to delay that a little bit tomorrow, make it a little later, so that we can revisit this discussion on goals and perhaps come to consensus, so that then Bruce could jump into his explanation and discussion of how the driver diagram process would work for us. And then in the remaining time that we have left tomorrow, Nancy can begin helping us work through identifying some of the drivers under each of the new goals that we established. And it could be that we would only have enough time to come up with just a very small number of the possible range of drivers under each goal, and then our charge after tomorrow will be back to the subcommittees, and we may think of restructuring the subcommittees a little bit based on where we end up tomorrow, and then really turning this work over to the subcommittees for the next month or two to flesh out some of the drivers and maybe fine tune the goals even a bit more. But that's kind of where we'll go tomorrow with this. Does that sound workable for everyone?
Yeah.
Yes, and Greg, this is Deborah Stonewalls. I have a request. Can you email us just a copy of the PowerPoint slide that showed those 5 goals from the National Alliance on Caregiving?
Yes, we sure can.
Okay.
We can do that.
Thank you.
Yeah, and what I would encourage everyone to do tonight, since I know that if Wendy and I will be thinking about this, then there's no reason why you shouldn't all be thinking about it, is looking at those goals, looking at what the Alliance had put forward, plus what we've discussed today. Use the space that we gave in the prep guide to maybe write out a few goal statements using that SMART acronym, make it specific, very measurable, achievable, realistic, and time-bound. See if you can come up with a couple of things that kind of begin to bring all of this together so that we can jump right into a discussion tomorrow. But Wendy and I will have something for you all to react to when we reconvene at 1 p.m. Eastern tomorrow.
Great, thank you.
All right, so with
Greg,
that,
and
we will,
the whole team, thank you.
thank you all so much. We will adjourn. I'll give you 20 minutes of your day back, and we will be back online tomorrow at 1 p.m. Eastern. Thank you.